When concern about somatic symptoms is severe and leads to significant distress or impairment, a somatic symptom disorder may be diagnosed. So a somatic symptom is when your psychological state causes physical symptoms to appear. Now, previously we believed, or some people believed, that these somatic symptoms were all in your head, and many doctors still believe this and will tell you when you come in complaining of some physical symptom that it's just all in your head and that you need to be on antidepressants or you need to see a therapist. Now, in a somatic symptom disorder, that may be able to help. However, not all physical symptoms are in your head or a somatic symptom, part of a somatic symptom disorder. So it can be difficult to tell when we're dealing with somatic symptoms that are, I don't want to say made up, but are caused by a have a psychological root versus is purely physical. And it's probably rare when an issue is purely physical because our psychological state affects us in many legitimate ways. So for instance, if you are under a great deal of stress, then many times your thyroid will start to fail and you may develop hypothyroidism, which has all sorts of symptoms like fatigue, depression, you feel cold all the time, your hair falls out, and so on. So that is a somatic symptom. It's something caused by your psychology, but it is still a real physical thing that is happening to your body. So when we are dealing with somatic symptom disorder, don't chalk it all up to it's just in your head, because your head is part of your body. Your psychology is part of the physical system of your body. All right, so that's somatic symptom disorder. Now, when somebody feels like they're out of it, and those feelings of being out of it become so persistent and recurrent that the person has a profound and unusual memory deficits, then we're talking about a diagnosis of dissociative disorder possibly being warranted. And this is one part of dissociative disorder could be multiple personality disorder, although we call it dissociative identity disorder now. So that is a type of dissociative disorder. In the past, somatic symptom disorders were formerly called somatoform disorders, and dissociative disorders were considered to be a form of neurosis, and neurosis is an anxiety-caused issue. All right, let's talk more about somatic symptoms and related disorders in more depth. So the category of somatic symptom and related disorders is actually new to the DSM-5. You may be looking at the DSM-4, so that it might be a little bit different in the DSM-5. For any assignments, just refer to your DSM-4, but I will also talk about the new version of the DSM-5 in this lecture. So anyhow, soma means body. People with somatic symptom disorders experience bodily symptoms, like I said, that cause them significant psychological distress and impairment. And those bodily symptoms may or may not be made up. Probably they are not made up, and certainly one of the requirements of being a therapist, counselor, nurse, doctor is to have respect for the person's experience and to, at the very minimum, give them the benefit of the doubt that any symptoms they report may actually be real. The four most important disorders in the somatic symptom and related disorders category are somatic symptom disorder, illness anxiety disorder, conversion disorder, and then factitious disorder. So with somatic symptom disorder, it's regarded as the most major diagnosis in this category. The new diagnosis includes several disorders that were previously considered to be separate in the DSM-4. The old disorders of like hypochondriasis, somatization disorder, pain disorder, those are gone now in the DSM-5. Most people would have previously been diagnosed with one of these disorders, will now be diagnosed with somatic symptom disorder. So hypochondriasis, somatization disorder, pain disorder, these are now all called somatic symptom disorder. For the diagnosis to be made, individuals must be experiencing chronic somatic symptoms that are distressing to them. So it's ongoing and it causes distress in some part of their life. They must also be experiencing dysfunctional thoughts, feelings, and or behaviors. This is actually a new psychological component. In the DSM-5, only one somatic symptom is required. So estimates are that the prevalence of somatic symptom disorder in the general population is around 5 to 7%. And it's very likely that the diagnostic criteria for somatic symptom disorder will continue to be modified over time because we actually don't know a lot about this area Sort of the connection between our psychology and our physical body is it's really recent in the past few decades that we've started recognizing it and researching it more. So some of the causes of somatic symptom disorders. For a long time, we thought that the symptoms developed as a defense mechanism against like unresolved or unacceptable unconscious conflicts, which is, of course, a very Freudian sort of idea. Current views take a much more cognitive behavioral approach. Several different models exist, but the core features tend to be similar. One, there's a focus of attention on the body. In other words, the person is really hypervigilant and has an increased awareness of bodily changes. So they're really focused on what's going on in their body, and they notice changes quicker than other people might. Two, the person tends to see bodily sensations as somatic symptoms, meaning that the physical sensations are attributed to illnesses. Now, they may be right or they may not be right, which is why we have different types of disorders. But they feel their heart race, and they may think that they have heart disease, when it really could be that they're just having anxiety, or it could be, I don't know, a medication they were taking or something like that. But the people who are actually diagnosed with a disorder, they're so distressed by it that now it's at the level of diagnosis of an actual disorder. So just remember, we have a continuum between normal behavior to abnormal behavior. The third core feature of most models is the person tends to worry excessively about what the symptoms mean and has catastrophizing cognitions, meaning they think they're going to die or something really bad is going to happen. So it causes really high levels of anxiety for them. And then four, because of this level of anxiety and worry, the person is very distressed and seeks medical attention for their perceived physical problems. Okay? So a normal person who is not diagnosable with this disorder may do the same things, but not to the level of distress that someone who eventually gets diagnosed with somatic symptom disorder has. Okay, so that's the difference. Experimental studies show that these individuals who have the diagnosis have an attentional bias for illness-related information. So they really pay attention to anything that has to do with the illness they suspect they have. In other words, like top-down cognitive processes rather than bottom-up processes, such as noticing differences in bodily sensation, seem to account for the problems that they have. Okay, and they're always looking to confirm this illness in themselves. Now, an individual's past experiences with illness do contribute to the development of kind of a set of dysfunctional assumptions about symptoms and diseases, and these may predispose a person to developing a somatic symptom disorder. So, for instance, if a person has had cancer previously and then they experience some symptoms, they may be very likely to kind of panic a little bit and think that maybe the cancer is back, whether it is or not. Negative affect is regarded as a risk factor, so this is negative emotional characteristics. Other characteristics that may be important are absorption and alexithymia. Alexithymia is reduced emotional clarity, and absorption is just another term for dissociation. And non-pathological levels of this do occur in the normal population. So again, there's a continuum, but alexithymia, absorption, and other cognitive failures, negative emotional affect, these are traits that have been implicated in dissociative psychopathology as well as somatic psychopathology too, or abnormal behavior. So research shows that when people who report a lot of physical problems are put into a negative mood, their reporting of physical symptoms increases. Now, does that mean that just because they're in a bad mood or they're depressed, they make these things up? Not necessarily. Maybe being in a negative mood increases the actual physical issues that they're having, which is completely possible because we do know stress has a major negative impact on the body. Patients are more likely to be female and to have high levels of comorbid depression and anxiety. Again, this does not mean anything to say that their symptoms are not real. In some situations they are, some situations they are not, but I would say, based on the research I have read, more often their symptoms are real than they're making it up. Somatic symptom disorders may be maintained to some degree by secondary reinforcements. So for instance, if they are rewarded in some way for being sick, maybe it's easier to survive in your family if you're sick. Maybe people take care of you if you're sick. So those would be secondary reinforcements. Maybe you like being in the hospital because it's the only place anybody ever takes care of you and you get a break. So But again, does that mean that they're making it up? Not necessarily. So I know I've said that over and over again, but I really want to emphasize that just because there's a psychological component to an illness does not necessarily mean that the illness is not real. People with somatic symptom disorders are not malingering. Okay? A malingerer is someone who's consciously faking symptoms in order to achieve a specific goal, such as winning a personal injury lawsuit. So I'm going to pretend I broke my ankle, or I'm going to pretend that I have some symptom in order to get people to take care of me. That's when the difference is that they're consciously doing it. So someone with somatic symptom disorder could be making it up, but they're not consciously doing it. They believe that they have this illness, or they believe that these symptoms mean that they're dying, or they have cancer, or whatever. So keep in mind that even if someone with somatic symptom disorders are making it up, that they're not making it up consciously, whereas somebody with a malingering disorder is. So there's a big difference. All right, so let's talk about how we treat somatic symptom disorder. The cognitive behavioral model provides a really good explanation of the causes of somatic symptom disorders, and they also provide good treatments that are widely used by psychologists to treat these disorders. Treatment usually focuses on assessing the patient's beliefs about illness and modifying the misinterpretations of their bodily sensations. So if your heart is racing, what do you believe that means? Why do you have that belief? And does it really mean that? Or could it just mean that you exercise particularly hard? Okay. So again, people with this disorder are having these bodily sensations. They're not making it up, but they may be misinterpreting what they mean and then kind of freaking themselves out over it. Techniques might include having the patient to induce these symptoms by sort of intentionally focusing on parts of the body to learn that if they have like this selective perception of bodily sensations, that could play a major role in their symptoms. So if you focus overly hard on your heart rate, then you can see how, because you change that focus, you might now induce that anxiety over it. And so they can learn to not focus so much by seeing the effects of their hypervigilance. Sometimes patients are also directed to engage in response prevention by not checking their bodies as they usually do, by stopping their constant seeking of reassurance, and so on. So again, this is one way that you can tell somatic symptom disorder from someone who's legitimately sick and is having issues, even if you can't find the cause of it. Are they doing these things? Are they looking for reassurance? Are they hypervigilant in checking their bodies, and so on? Cognitive behavioral techniques are also widely used in the treatment of somatic symptom disorder that involves pain. So treatment programs generally include like relaxation training, support and validation that the pain is real, scheduling of daily activities, cognitive restrictions, reinforcement of no pain behaviors. So fibromyalgia has been the big one in the past for somatic symptom disorder, that it's all in your head, you're making it up, you're focusing too much on your aches and pains, and so you're creating this disorder. And for decades, people who had fibromyalgia were diagnosed with somatic symptom disorder and basically told they were making it up. Now we do know that fibromyalgia is a very real illness, and these people are genuinely experiencing pain, many times excruciating pain. So imagine, put yourself in the shoes of this person with fibromyalgia being told by the doctors that you're crazy and you're making it all up and you need to see a therapist. Okay, so we have to be really careful with somatic symptom disorder, that there are illnesses out there that we don't understand. There are illnesses out there that we don't know about, and to just tell somebody that they're crazy, which is something you should never tell anybody, period. But when they're genuinely sick and then you're telling them that they're making it up, is just a very disrespectful thing. So somatic symptom disorder is something that should very rarely, and only with great amounts of training, that you ever diagnose somebody with. All right, anyhow, let's go on to the next one, illness anxiety disorder. So this is also new to the DSM-5. People with this disorder have high anxiety about having or developing a serious illness. Okay, so they may actually be sick, or they might be afraid that they're going to get sick. And what the disorder is about is the level of anxiety that they have over this. So the anxiety is distressing, it's disruptive, but it doesn't match the amount of symptoms that they actually do have. So the biggest difference between illness anxiety and somatic symptom disorder is the severity of the symptoms. People with somatic symptom disorder usually have more comorbid conditions. Comorbid means multiple things going together, and they visit doctors more frequently. Okay. Conversion disorder is characterized by the presence of neurological symptoms in the absence of a neurological diagnosis. And it was formerly called hysteria. So it's often believed to be triggered by anxiety, by stress, and patients have symptoms that affect, or deficits, that affect their senses or their motor behaviors. So they might become partially paralyzed, they might become blind or deaf, they might have limb shaking, loss of consciousness that resembles seizures. So it can be a pretty scary thing to have. And again, they're not making it up. Okay? I'm going to say this a million times in this lecture. They're not making it up. They're having psychological distress that causes a physical reaction in the body that triggers a neurological symptom. It's completely possible that changes in stress hormones and other various chemicals in the body can cause neurological things to happen that are usually temporary. My mom was in graduate school with 3 children under the age of 5, and her parents and her younger siblings all moved in with her, and she was having to support her and her husband. My dad had to support everybody, and she was under intense stress, and she went blind. And fortunately, she had a doctor who said, you have conversion disorder, but this is real. It's not all in your head. And so you need to go relax, and you need to just stop worrying about things for a little while, and you'll be able to see again. And sure enough, after she was able to decrease some of her stress and take a break, her sight came back. Now, did she make that up? No, she did not make it up. There was actually a physical change in her brain, in her body, that caused neurological symptoms despite not actually having a neurological diagnosis of blindness. There's no damage to her, or no testable damage. You couldn't have done a lab test or an MRI or whatever and seen the damage that was happening to her eyes, but potentially there was inflammation or something caused by this stress, the stress chemicals in her body that caused this to actually happen. So again, if somebody has conversion disorder, don't just say that they're crazy and it's all in their head. Patients with conversion disorders have these issues that strongly suggest a medical or neurological, I've already talked about this, neurological condition. Okay, range of conversion disorder symptoms. So there's 4 categories of symptoms: sensory, motor, seizures, and a mixed presentation of the first 3 categories. So my mom had sensory, so she lost her eyesight. You might lose your hearing. Motor, you might lose your ability to move things. Deficits are most common in the visual system, especially blindness or tunnel vision, the auditory system, especially deafness, and in sensitivity to feeling, especially the various anesthesias, which is where a person loses feeling in part of their body. One of the most common is glove anesthesia, where a person can't actually feel anything on their hand in the area where a glove would be worn. The loss of sensation doesn't seem to make any anatomical sense. However, if we understood the stress reaction and the effect of stress on the neurological system, these things might make sense. And the fact that there are common deficits, the visual system, especially blindness and tunnel vision being the most common, deafness being the second most common, this really does show that there probably is a legitimate physical reaction going on, that it's causing the same issues in people on average. With conversion blindness, the person reports not being able to, or reports being unable to see. However, they're often able to navigate around a room without bumping into furniture or other objects, which is one reason why doctors often say that they're crazy, it's all in their head, and that they're making it up. But that's not necessarily true. There's many different aspects of our senses in our brain. So, for instance, you may, and in this case, they obviously are getting visual information into their brain, but their brain isn't processing it. So perhaps stress hormones are affecting some place in their brain that processes the visual information and brings it to your conscious awareness. That part could be the bottleneck where information is stopping. So you're still seeing things, but you're not aware that you're seeing things. 100% possible. With conversion deafness, they say that they can't hear, but if somebody calls their name, they turn to the person. Okay, so again, stress is obviously affecting the part of the brain that is converting the sensory information that comes in into conscious awareness. It can be really difficult to diagnose conversion disorder because it does appear, as many medical conditions do appear. So the criteria that we usually use for distinguishing between conversion disorders and real neurological disorders include: 1, the frequent failure of the dysfunction to conform clearly to the symptoms of a particular disease or disorder simulated. So even though it seems like true blindness, there's a weirdness to it. It doesn't quite match blindness, such as being able to walk around furniture. The nature of the dysfunction is highly selective, so you may not always be blind, and may not be blind in every situation, or deaf, or whatever. And then under hypnosis or narcotic drugs, the symptoms usually can be removed, changed, or reinduced at the suggestion of the therapist. And that's not what would happen with real blindness or a real seizure disorder or so on. Okay, so there are differences in that. However, again, that does not mean that it's not actually happening. It doesn't mean that the person can see and they're just making it up for attention, which is what a lot of doctors say. Conversion disorder was really recognized in World War I with shell-shocked, what we call shell-shocked, or soldiers with PTSD. And then we also saw it a lot during World War II. So obviously it is very strongly related to anxiety. And it's found in approximately 5% of people who are referred for treatment at neurology clinics. So in the general population it would be a lot lower. But people going to a neurological clinic and saying that they have this issue, 5% of the people who go there actually have conversion disorder. Okay, so the prevalence in the general population we don't know, but the highest estimates are about 0.005%, which is really low. Okay, and we have a decreasing prevalence, and that might be because we're understanding medical and psychological disorders more, and so we're able to catch this. Interestingly, it's more common among rural populations from lower socioeconomic circles. Okay, and it occurs, though this is unsurprising, occurs 2 to 3 times more often in women than in men. And that's not surprising because women tend to, when they're under stress, they tend to have more internal symptoms rather than external. So men tend to become more angry, maybe violent, and women tend to become more depressed, more anxious. That's obviously a generalization, but it's more often true than not. And another thing that happens is a rapid onset after a significant stressor. And then this often, it resolves within 2 weeks if the stressor is removed. So if you had somebody who was sent to you from a doctor, and the doctor is saying this person has conversion disorder, then one of the things you would look for is what was the triggering event. And if there is no triggering event, then maybe they need to go back to a different doctor for more diagnosis, because it's very rare when a conversion disorder happens without a significantly stressful triggering event. Okay, so that would be the biggest thing that you would look for. And also the exceptions. So, turning their head when their name is called or so on. Okay. Let's just skip the causes because we talked a lot about that. Treatment of... Well, before I go on, let me point out this slide, which is an MRI of a person with conversion disorders brain. So in this MRI, they have anesthesia disorder, where they don't feel anything in their left hand. And so they stimulated both the left hand and the right hand, and they looked in the brain for activity. So when their right hand was stimulated, you see their brain lit up. But when their left hand was stimulated, there was no activity in the brain. So the brain is literally not processing any information, any sensory information from the hand, which proves that these people are not making it up. Now, could their psychology and their stress levels be causing this physical change to happen? Sure. But are they making it up? No. It's actually a real physical change. Something has actually changed in their brain. So we don't have very many studies, so we don't really know how to treat it very well. But what we have seen success with is a behavioral approach, where there are certain things the client is told to do to kind of basically decrease stress levels, increase happiness. So to move, to walk, to do things, to pray and praise them when they do. So these have been shown to to create improvement. But it's not really surprising, because this is also the same thing with depression. So if someone's depressed, then they're often they're often told to make a list of on their own of the things that would make them happy, and then they're prescribed to do those things. So if it makes you happy to go for a walk, then go for a walk no matter how depressed you are. Or if it makes you happy, like if you didn't have the depression, it would make you happy to go to the beach, then even if you're depressed, just go to the beach. And don't expect it to do anything for you, just go to the beach. And what they found is it does do something for you. It alleviates depression. All right, factitious disorder. So this is the one where the person is lying. So they're intentionally producing psychological or physical symptoms, or both, and their goal is to get the benefits of being the sick person. This might be attention, the concern of the family and the doctors, that the nurse takes care of them, and so on. Now, historically, this disorder has been very stigmatized. People, especially doctors, don't take it seriously. But it is something that should be taken seriously, because there's something wrong with a person who does this, okay? So even though they're not really sick, they're sick in a psychological sense. So they do still need help, okay? And it can get really serious. Like, they can do really bad things to themselves. And see, that's one of the things that you have to recognize also, is that they actually are doing things to themselves in many cases, not necessarily making it up. So they could literally be hurting themselves. They could be giving themselves a real illness. And just because they're doing it because they have a psychological disorder doesn't mean that they're not actually sick. So you can see this is a really boggy sort of area. There's no obvious lines in the sand to give you an understanding of these somatic disorders. It's very difficult to treat. It's very difficult to recognize. So for somebody with factitious disorder, they don't usually receive any obvious external rewards. Okay? They don't get money for it. They don't get a pay raise or a promotion or whatever. But there are some rewards. Usually it's the attention that they want. So a person who is malingering is intentionally producing or exaggerating their physical symptoms. Okay. And those people are motivated by external incentives, such as avoiding work, military service, evading criminal prosecution. Okay, so that's a malingerer. A malingerer is different than somebody with a factitious disorder, because the factitious disorder, they're not receiving those obvious external rewards. It seems like the amount of people who have factitious disorder is about 0.5 to 0.8% of people in a general hospital setting. So in the general population, it would be way, way lower. So this is a very rare disorder, which also means that if you're suspecting somebody has factitious disorder that you're dealing with as a nurse or a doctor or so on, then chances are they don't, because this is very, very rare. Okay? We also have factitious disorders imposed on another, and this is sometimes referred to as Munchausen syndrome by proxy. So this is kind of famous, even though it's extremely rare. And this is when you produce a medical or psychological disorder in another person. And it's oftentimes the child or somebody who's under their care, maybe an elderly person, but more often than not, it's the person's child. Okay? But again, this is super rare. It's kind of one of those really like Hollywood-friendly ones that movies and shows love to have a story about, but it's insanely rare. So chances are this is not happening. So if you do suspect somebody of having a factitious disorder or factitious disorder imposed on another, then be really careful before you make the accusations. Just recognize how rare it is that somebody actually does have this. However, having said that, it does happen. It is something that is possible. So you have to be aware. So it can be really difficult to tell the difference between a somatic symptom disorder or the illness, anxiety disorder, or factitious disorder, and to make a correct diagnosis. You should not make a diagnosis with this at all unless this is your specialty. There is a responsibility here to be responsible in diagnosing and labeling someone, because these are serious disorders to label someone with. It's like you wouldn't diagnose someone as schizophrenic unless you really understood schizophrenia. People who have malingering and who have factitious disorders, they are consciously perpetrating frauds by faking symptoms or causing symptoms that are not actually created by a real disease. And you can often see this in how the person is acting. There are other sort of comorbid conditions. Usually the person, they just don't strike you as a healthy, mentally healthy individual. There's something off about them, something that just makes you a little suspicious. But that's so subjective. You can't really use that as criteria. However, if you feel like something's off, then you may want to investigate more before an actual diagnosis or accusation can be made. Now, individuals with conversion disorders and other somatic symptom disorders, these people are not consciously producing their symptoms, okay? They're not doing it on purpose. They're not doing it to be bad people or to get something. They usually feel like they're victims of their symptoms. They're very willing to discuss them, to have tests. So if you think this person is malingering or they have a factitious disorder, then talk to them about their illness. Talk to them about their history, about what their plan is, what they want to do. If they're really willing to discuss them, then they most likely do not have malingering or factitious disorders. Okay. However, they're usually not upset when an inconsistency in their behavior is pointed out. Okay. So individuals feigning the symptoms, such as malingerers or factitious people with factitious disorder, they're more likely to be defensive, evasive, suspicious. Okay, so again, there's just something off. All right, so those are the somatic symptom disorders and related somatic disorders. We'll talk about dissociative disorders next. These tend to be kind of put together because they're both believed to be caused by stress and anxiety.